Welcome to this video where we're going to discuss sample collection, test requests, guidelines, and diagnostic modalities in precision oncology in prostate cancer. So cancers can develop in the context of germline mutations which are inherited or somatic gene alterations that are acquired only within the tissue itself. Germline or somatic alterations involved in DNA damage repair or DDR, either through the homologous recombination repair pathway or the mismatch repair pathway, are found in about 10% of patients with localized prostate cancer, but up to a quarter of all individuals with metastatic disease. And the most common alterations are in the BRCA2 gene, which is the most well-known direct HRR-related gene, ATM genes, and CDK12, but there are mutations in plenty of other DDR genes that can be relevant in prostate cancer. DDR genes have wide-ranging clinical implications for prostate cancer patients, including in terms of disease prognosis and also for predicting response to precision oncology treatments, such as PARP inhibitors in the context of BRCA mutations, or immune checkpoint inhibitors in the context of alterations in the mismatch repair pathway. Prostate cancer patients with HRR-related gene alterations, particularly BRCA2, are associated with more aggressive disease in general and poor outcomes on standard of care therapies such as androgen receptor pathway inhibitors. But these gene alterations are also a predictive biomarker for PARP inhibitor response. So PARP inhibitors can be an optimal treatment for patients with HRR-related gene alterations. The several other genes that are involved in DDR can also have biomarker relevance in prostate cancer, but their effect sizes can be smaller, or the effect itself can be less well characterized due to the rarity of those genes. Molecular testing for BRCA or HRR-related gene alterations for prostate cancer is standard of care in all patients with metastatic disease, as outlined within several different international guidelines. And according to the guidelines, somatic or tumor tissue testing should be performed in patients with metastatic castration-resistant prostate cancer, ideally as early as possible within their disease course. And germline testing is recommended in all prostate cancer patients with metastatic disease, and also in some patients with localized disease, such as those with family or personal history of related cancers. Somatic-only testing is not sufficient to make conclusions about the germline, and so germline testing and somatic testing should ideally be conducted in parallel. And the minimum set of genes for genomic profiling of the tumor in patients with prostate cancer who meet criteria for testing ideally should include BRCA1, BRCA2, and ATM, but there are several others that are included on international guidelines, including CDK12 and those in the mismatch repair gene alteration pathway. But tumor testing panels should ideally be aligned with germline testing panels as much as possible, because the germline panels typically include more genes. Next generation sequencing is the standard method for both germline and tumor testing in prostate cancer. This approach allows the simultaneous assessment of multiple genes and also the evaluation of different classes of alterations, including mutations, copy number variants, and structural rearrangements. There are several different specimens that we can use, including tumor tissue, so that's either an archival biopsy or a metastasis-directed biopsy. We can assess the germline using blood or saliva, or we can use a liquid biopsy which relies on circulating tumor DNA, ctDNA. The first choice of specimen is typically the archival primary or metastatic biopsy. But if that tissue specimen is not available or it fails due to suboptimal specimen, we can fall back on a fresh tumor biopsy if that's possible in the patient, or we can use liquid biopsy and test that plasma cell-free ctDNA in the blood. It should be noted that for ctDNA testing, it's really important to do that testing at time of disease progression, when circulating tumor DNA is likely to be at its highest. During treatment, ctDNA is typically suppressed, increasing the chance of false negatives. Of course, blood and saliva testing for germline can be done at any time. There are a number of challenges that arise during molecular testing, and it's important to recognize these in order to help reduce pre-analytical errors. Access to tissue, insufficient tumor content within samples, and insufficient breadth of the genes tested all cause issues downstream with test results. Ideally, you should be using good quality tissue with high tumor content, and you should be using panels that are comprehensive in nature. It's really important when you're ordering a test that you understand these variables and that you understand what the local test that you use reports in terms of the number of genes and the types of alterations that they report. There are also several challenges in actually interpreting results that are not necessarily super easy to understand. So that can include things like false negatives, whether or not the allelic status of an alteration is reported, whether or not an alteration is actually actionable, or whether it falls in the germline or only in the tumor tissue, so it's somatic. And it's important to remember that we work within multidisciplinary teams. And so for these types of issues, please reach out to your pathologist or your clinical genetics or genomics expert within your local centers and ask for clarification around anything that seems unclear. We hope you found this video useful, and you can find more detailed slides for download on the Core2Ed website.